As a physician with more than 20 years of experience in functional and integrative medicine, I have witnessed the profound impact that chronic fatigue syndrome, CFS, has on my patients' lives. Far too often, people, especially women, are told that their symptoms are all in their head or that they simply need to push through their fatigue. This dismissive attitude is not only unhelpful, it is harmful. Chronic fatigue syndrome is a real, complex, and treatable medical condition that requires thorough evaluation. In this guide, I will share the clinical insights, diagnostic strategies, and treatment approaches that I use daily in my practice. What is chronic fatigue syndrome? Chronic fatigue syndrome, also known as myalgic encephalomyelitis, ME, is a multi-system disorder characterized by severe, persistent fatigue lasting at least 6 months, post-exertional malaise, PEM, where even minor physical or mental effort leads to a significant worsening of symptoms, non-restorative sleep, patients wake up feeling just as exhausted as the day before, cognitive dysfunction, brain fog, pain, orthostatic intolerance, such as postural orthostatic tachycardia syndrome, POTS. Why women are affected more often. Women are 2 to 3 times more likely than men to develop chronic fatigue syndrome. Several factors contribute to this. Hormonal fluctuations, especially involving estrogen and progesterone. A higher tendency toward autoimmune disorders. Increased rates of thyroid dysfunction, such as Hashimoto's thyroiditis. Social and medical bias, which can delay proper diagnosis. The biological foundation. Chronic fatigue syndrome is not a psychological illness. It is a biological illness with measurable abnormalities in mitochondrial dysfunction, leading to impaired energy production, immune dysregulation, resulting in chronic inflammation, nervous system and autonomic dysfunction, hormonal imbalances, particularly involving the hypothalamic pituitary adrenal axis. The 10 root causes. Understanding the root causes of chronic fatigue is essential for effective treatment. In my clinical practice, I have identified 10 key factors that contribute to the development of chronic fatigue syndrome. Every patient is different, but these patterns appear repeatedly. 1. Adrenal dysfunction. The hypothalamic pituitary adrenal, HPA axis, is the body's primary stress response system. In chronic fatigue, we often see cortisol imbalances. Levels may be too high, too low, or dysregulate. Low DHEA, a hormone that supports energy, immune function, and stress resilience. An overactive sympathetic nervous system, keeping the body in a constant state of fight or flight. How I test? 4-point salivary cortisol testing to measure daily cortisol rhythm, DHEA's levels, heart rate variability to assess autonomic nervous system function. How I treat? Adaptogenic herbs, phosphatidylserine, often used at night to regulate elevated cortisol, vitamin C, 1 to 2 grams daily to support adrenal function, targeted lifestyle changes focused on stress regulation. 2. Mitochondrial dysfunction. Mitochondria are the power plants of your cells, responsible for producing ATP, the body's primary energy currency. In chronic fatigue syndrome, mitochondria are often impaired, leading to ATP deficiency, increased oxidative stress, lactic acid buildup. How I test? Organic acids test, or OAT, CoQ10 levels, carnitine levels. How I treat? CoQ10 supplementation, L-carnitine, 1 to 2 grams daily, riboflavin, 100 to 400 milligrams daily, PQQ, D-ribose, 5 grams twice daily. Clinical note: D-ribose can bypass blocked energy pathways and help restore ATP production. 3. Chronic infections. Chronic infections are a common and frequently overlooked cause of chronic fatigue. These may include Epstein Barr virus, or EBV, Lyme disease, mycoplasma, human herpes virus 6, or HHV6, Candida overgrowth, particularly common in women due to hormonal influences. How I test? EBV early antigen IgG, Lyme Western blot, more sensitive than standard CDC criteria, PCR testing for active infections, Comprehensive stool analysis. How I treat. Valacyclovir, 500 mg twice daily, when indicated. Monolaurin, 600 mg daily. Japanese knotweed, 500 mg daily. Fluconazole for fungal overgrowth when appropriate. Clinical case example. One patient with active EBV infection and candida overgrowth experienced significant improvement after 6 months of targeted treatment. 4. Gut dysfunction. Gut health plays a central role in chronic fatigue. Common findings include increased intestinal permeability, leaky gut, small intestinal bacterial overgrowth, SIBO, dysbiosis, estrogen dominance, often connected to impaired gut detoxification. How I test. Comprehensive stool analysis, such as GI map, lactulose breath test for SIBO, zonulin testing to evaluate gut permeability. My 4R gut repair program. 1. Remove inflammatory triggers and pathogens. 2. Replace digestive enzymes and stomach acid when needed. 3. Reinoculate with beneficial probiotics, such as Saccharomyces boulardii. 4. Repair the gut lining with L-glutamine, zinc carnosine, and supportive nutrients. In my clinical experience, approximately 70.
Chronic fatigue syndrome is closely linked to immune system dysfunction. This may present as low-grade chronic inflammation, autoantibodies such as anti-nuclear antibodies, ANA, mast cell activation syndrome, MCAS, Th1, Th2 imbalance. How I guessed. Cytokine panel to evaluate immune balance, ANA testing for autoimmune activity, tryptase levels for mast cell activation, comprehensive thyroid panel, including antibodies. How I treat. Low-dose naltrexone, 1.5 to 4.5 milligrams nightly, curcumin, 500 to 1,000 milligrams daily, omega-3 fatty acids, EPA, DHA, vitamin D3, 5,000 to 10,000 IU daily when indicated, quercetin, 500 milligrams twice daily. Clinical example. A 50-year-old woman with Hashimoto's thyroiditis, mast cell activation, and elevated IL-6 experienced substantial symptom reduction after immune modulation. Sex, neurological dysfunction. Neurological symptoms are common and often debilitating in chronic fatigue syndrome. These may include orthostatic intolerance, including POTS, neuroinflammation, elevated quinolinic acid, glutamate, dopamine imbalance, limbic system dysregulation. How I test. Tilt table testing. Neurotransmitter testing, urine or blood, brain MRI or PET scan when indicated, heart rate variability monitoring. How I treat. Methylated B vitamins, lion's mane mushroom, fludrocortisone when clinically appropriate, acetyl L-carnitine, 500 milligrams twice daily, ginkgo biloba. Women with CFS appear to have a higher incidence of POTS, potentially due to estrogen's influence on autonomic regulation. 7. Toxic burden. Toxic exposure is a significant and often underestimated contributor to chronic fatigue. Common toxic factors include heavy metals, mercury, lead, mold toxicity, water-damaged buildings, chemical sensitivities, glyphosate, VOCs. How I test. Provoked urine heavy metal testing, using DMSA or EDTA, mycotoxin testing, environmental exposure assessment, my detox protocol, binders, chlorella, activated charcoal, infrared sonotherapy, glutathione support, N-acetylcysteine, 600 milligrams daily, liposomal glutathione, liver support, milk thistle, 300 milligrams daily, alpha-lipoic acid, 300 milligrams twice daily. Clinical example. A 45-year-old patient with elevated mercury levels from amalgam fillings and mold exposure improved significantly following chelation therapy and mold remediation. 9. Hormonal imbalance, especially in women. Hormonal dysregulation is a major contributor to fatigue. Common findings: estrogen dominance, low progesterone, thyroid dysfunction, especially Hashimoto's, low testosterone. How I test. Dutch hormone test, comprehensive thyroid panel, TSH, free T3, free T4, reverse T3, antibodies. How I treat. Bioidentical progesterone, DIM, 100 to 200 milligrams daily, selenium, 200 micrograms daily, pregnenolone, 10 to 30 milligrams daily, when indicated. Clinical case. A 38-year-old woman with estrogen dominance and low progesterone experienced an 80% improvement after hormone balancing therapy.
9. Nutrient deficiencies. Micronutrient deficiencies are extremely common in chronic fatigue syndrome. Key nutrients: magnesium, vitamin B12, iron, especially in menstruating women, vitamin D, CoQ10. How I test? Micronutrient testing, e.g. SpectraCell. Blood levels of ferritin, B12, folate, vitamin D. How I treat? Magnesium, 400 to 600 milligrams daily, glycinate or malate form. Vitamin B12, methylcobalamin when appropriate. Iron, 30 to 60 milligrams daily if deficient. Vitamin D3, 5,000 to 10,000 IU when indicated. 10. Limbic system dysfunction. The limbic system, including the amygdala and hippocampus, plays a major role in chronic stress response. In chronic fatigue, it may become hypersensitized, leading to increased sensitivity to light, sound, and stress, persistent fatigue due to chronic neural overactivation, emotional dysregulation. How I address it? Neuroplasticity retraining programs, such as DNRS, vagus nerve stimulation techniques, cold exposure, breathwork, GABA support, L-theanine, phosphatidylserine. Clinical example: a 50-year-old man with severe sensory sensitivity improved by 75% after neuroplasticity training and vagal support. Продолжаю перевод заключительной части. My step-by-step treatment plan. Phase 1. Stabilization and inflammation reduction. Month 1. Goals: prevent further damage, improve sleep and stress resilience, support gut health and correct nutrient deficiencies. Protocol: diet. Follow an anti-inflammatory diet, whole foods, elimination of processed sugar, refined carbohydrates, inflammatory oils. Sleep: aim for 7 to 9 hours of restorative sleep nightly. Stress management: daily stress reduction practices, breathing exercises, meditation, HRV tracking. Gut repair: implement the 4R gut protocol. Supplements: begin mitochondrial support, CoQ10, magnesium, B vitamins. Phase 2. Targeted treatment, months 2 to 4. Goals: treat underlying infections, modulate immune dysfunction, support detoxification, correct hormonal imbalances. Protocol: infections: use targeted antivirals, antimicrobials, or antifungals when indicated. Immune modulation: low-dose naltrexone, omega-3s, vitamin D. Detox support: infrared sauna 2 to 3 times per week, binders, glutathione support. Hormone balancing: address thyroid dysfunction, estrogen dominance, adrenal imbalance. Phase 3. Repair and rebuilding, 6+ months. Goals: restore mitochondrial energy production, repair neurological and hormonal balance. Gradually reintroduce physical activity without triggering post-exertional malaise. Protocol: continue mitochondrial therapy, PQQ, carnitine, ribose. Support neurotransmitter balance. Graded activity only after PEM is controlled. Long-term lifestyle optimization. Recovery is gradual. The body must be rebuilt systematically. Common mistakes to avoid: relying on stimulants, caffeine, Adderall, temporary boost, long-term crash. Skipping meals worsens blood sugar instability. Ignoring sleep. Recovery is impossible without quality sleep. Pushing through exercise may trigger severe relapses. Taking random supplements without testing. Ignoring hidden infections or toxic exposures. Real clinical stories. Patient 1. From bedbound to hiking. A 38-year-old woman with chronic EBV reactivation and severe fatigue. After 8 months of targeted antiviral and immune therapy, she returned to hiking and full-time work. Patient 2. Neuroinflammation case. A 50-year-old woman with elevated quinolinic acid and severe brain fog. After neuroinflammatory support and mitochondrial therapy, she experienced dramatic cognitive recovery within 10 months. Patient 3. Mold toxicity. A 45-year-old woman with mold exposure and heavy metal burden. Following detoxification and environmental remediation, she reported a major restoration of energy and cognitive clarity. When to seek immediate medical attention. Seek urgent medical care if you experience severe muscle weakness, unexplained weight loss, new neurological symptoms, severe depression, or suicidal thoughts. These may indicate conditions beyond CFS that require immediate evaluation. Essential testing. Proper evaluation should include 4-point salivary cortisol, full thyroid panel, TSH, free T3, free T4, reverse T3, antibodies, organic acids test, OAT, comprehensive stool analysis, inflammatory markers, CRP, ESR, toxicology screening, heavy metals, mold if indicated. Do not guess. Test. Final advice. Work with a knowledgeable provider. Master the fundamentals: sleep, diet, stress regulation. 3. Be patient but persistent. Recovery takes time.